Hello, welcome to Key Insights. We're reporting today from the Great Debates and Updates in GI Malignancies 2018. I'm Dr. David Ilson from Memorial Sloan Kettering Cancer Center, and I have my colleague, Dr. Axel Grothey from the Mayo Clinic, Scottsdale, Arizona.
Yeah, thank you.
So we're going to review some of the updates and presentations in non-colorectal cancer that we enjoyed at today's meetings. And I think we had a vigorous debate about the role of routine next-generation sequencing and genomic profiling in esophagogastric cancer.
Yeah, I mean, as you know, there are very few targeted agents that actually have made inroads into advanced gastroesophageal cancer. I mean, the only targeted agent we really have is anti-HER2, trastuzumab, and actually only right now in the first-line setting, not even in the second-line setting, not even with pertuzumab and other agents. Expanding upon the portfolio of, let's say, targets that we have, I think is interesting. I personally don't consider VEGF inhibitors targeted agents. They're kind of unspecific agents. But so what do you think? Are you profiling all your patients?
Yeah, I think, we have the research access to do this, and the price of this profiling is coming down. And already routinely now we're looking at amplification of HER2. We usually do immunohistochemistry as the initial screen and do more genomic-based testing like FISH only for the indeterminate patients. And as you said, the only really approved targeted agents are HER2 targeted agents in first line only, and then the VEGF targeted agent ramucirumab in second line, but there's no biomarker or genetic or genomic test for VEGF-targeted therapy. The other class of agents are anti-PD-1 drugs, because we know
there is a biomarker. Yeah.
There is a biomarker, actually two biomarkers,
right.
Because now a drug like pembrolizumab is now approved in chemotherapy refractory esophagogastric cancer if either the tumor is PD-L1 positive, and that's based on the large expansion cohort data for pembrolizumab, 260 patients, where they did see some responses and some were durable. And I think even more significant, the MSI-High esophagogastric cancers, where the response rate in a small number of patients exceeded 50 to 60%. So we now really have three classes of targeted agents. But the problem with genomic sequencing, yes, we identify potentially targetable mutations, but we don't have drugs to treat these mutations. And what we're seeing in esophagogastric cancer is one mutation or one gene amplification doesn't translate into the drugs being effective. We've had negative studies for EGFR inhibitors, for MET inhibitors, even in a biomarker-selected population. So there are probably 30–40% of these cancers have gene amplified pathways, but that doesn't translate into drugs being effective or us having drugs that target mutations. So I think we're learning and accumulating data and understanding the complexity of the genomics of these cancers. We do now have targeted agents approved that we've talked about. And I think we're going to learn about resistance mechanisms and how we overcome resistance. Do we have to target multiple mutations? Most of these cancers are not driven by one mutation or amplification. They have other pathways that are co-amplified or affected.
Yeah. Another topic we discussed in a debate in terms of management of gastric and gastroesophageal cancer was neoadjuvant treatment. The pitching chemotherapy alone, the FLOT regimen, which showed survival benefit over the ECX regimen, and the CROSS study, which was the carboplatin paclitaxel plus radiation therapy. It was an interesting debate, I think. First of all, I think if we talk about gastric cancer, not gastroesophageal cancer, I think the consensus from our end is that FLOT would be the most appropriate regimen to use in the perioperative curative setting in probably a healthy patient, otherwise healthy, a good performance status patient. So this has really eliminated, in my eyes, the use of an EC or epirubicin-based combination therapy. I think, David, you and I agree that epirubicin has no role in the management of gastroesophageal cancer at all.
And not in metastatic disease either.
Not in metastatic, so that should be eliminated. And I think you and I have been on the same page of this for a long time. Now, for gastroesophageal adenocarcinoma, the patients population that we normally treat with radiation therapy up front, neoadjuvant radiochemotherapy, I think the data are still strong in terms of local tumor control, which is important not only in terms of mortality, but also morbidity for patients later. So in my clinical practice, and I think it mirrors your practice, for GE junction adenocarcinoma, the preferred regimen is carboplatin, paclitaxel plus radiation therapy along the lines of the cross regimen.
Yeah, I think the FLOT data really support its use as perioperative chemotherapy in gastric cancer.
Yeah.
The problem is if you look at the bulk of the data for chemotherapy alone in esophagus and GE junction cancers, chemotherapy alone results in high rates of palliative resections, R0 curative negative margin resections in only about 60% of patients. If you don't get an R0 resection, you will not survive. And that also likely translates into higher local failure rates. To me, the compelling data for chemoradiation are the R0 resection rates in the high 80s to 90% range, significant reductions in local recurrence, and the exposure to chemotherapy is relatively brief. So I think for distal gastric cancers, in a patient that can tolerate a triplet regimen, FLOT would be considered the standard. In a patient that wouldn't tolerate 3 drugs, we would do either capecitabine oxaliplatin or 5-FU-oxaliplatin. There's also a role if we do upfront surgery in gastric cancer and there's a good D2 resection. Our guidelines support the use of postoperative adjuvant chemotherapy is also beneficial. For GE junction esophagus cancers, I think certainly the standard of care in the US, which is endorsed by guidelines, is a preference for combined chemoradiation. And there are 3 randomized trials ongoing that are addressing this issue in which FLOT-based treatment is being compared to chemoradiation-based treatment. So hopefully we'll get an answer from the ongoing trials, but I think outside of a study, the data really compel us to consider combined chemoradiation for that disease site.
Yeah, and so the other discussion we had was on pancreas cancer and management of early stage pancreas cancer. And I think we've heard from an expert opinion level that there's, even in resectable pancreas cancer, there's a shift toward neoadjuvant therapy, neoadjuvant chemotherapy, with or without radiation therapy, based on the fact that we still, even if we have a resectable pancreas cancer, the long-term outcomes are not great, even with optimized adjuvant chemotherapy. So there's a shift toward neoadjuvant treatment with FOLFIRINOX and gem-nab-paclitaxel. But even if we had discussions about the optimal post-operative adjuvant chemotherapy if patients go to surgery right up front. And right now, the standard of care, I think endorsed by the SBAC4 data and guidelines, is gemcitabine plus capecitabine. So that's kind of the standard of care, but we all anticipate that within 2018, we'll see the results of 2 trials which look at more enhanced chemotherapy with FOLFIRINOX, modified FOLFIRINOX, in a European study and a kind of an international study, worldwide study with nab-paclitaxel and gemcitabine. So I do believe, and I hope, and I think this is kind of a consensus of our panelists, that the adjuvant therapy will shift in 2018 toward combination therapy outside of gemcitabine plus and capecitabine, which I consider standard of care right now.
Yeah, I think the problem with the upcoming trials is that the control arm is gemcitabine, and we now have evidence that combination therapy with gemcitabine and capecitabine is better. So right now,
with a hazard ratio of 0.82.
Right now, well, that's if you look at all patients, but for node negative, for the margin negative patients, the benefit was more substantial. So I think that combination chemotherapy is preferred in the adjuvant setting. Right now, a combination of gemcitabine and capecitabine is the standard. If data emerge that either FOLFIRINOX and or gemcitabine or Abraxane are better than gemcitabine alone, then they also emerge as treatment options. I think not every patient that gets a pancreatectomy is going to be a candidate for FOLFIRINOX. And Abraxane also has fairly substantial toxicity. So I think what this is going to allow us to do is individualize treatment, that we may have several adjuvant options with combination regimens. But again, we have to see what the data show. Just because something is more effective in metastatic disease doesn't mean it translates into a survival benefit in the adjuvant setting. But certainly, our hope is we have more options and that alternative combinations beyond gemcitabine, capecitabine may be present for the adjuvant treatment of pancreatic cancer.
And again, shifting it to the neoadjuvant phase, I think that's really the future that we'll see.
Yeah, I think neoadjuvant, I mean, there it's a different situation. where you really want to see tumor regression, so you want to give the most active systemic regimen. And there are comparative studies now of gemcitabine Abraxane versus FOLFIRINOX. There's also a debate in resectable patients whether or not we should include radiation preoperatively. Postoperatively, radiation therapy has an uncertain benefit. Over and over, the adjuvant trials do not show clear survival differences whether we give patients chemotherapy alone or combined chemoradiation. Yep. Hopefully, we'll get some answer from the RTOG study, which is comparing adjuvant chemotherapy with or without radiation. Then we talked actually about the more borderline resectable patients. That might be a group in which sequencing chemotherapy and radiation may be more important before a contemplated surgery. But that issue is also the subject of a randomized trial and other controlled studies looking at chemotherapy alone or chemotherapy sequenced with radiation, followed by surgery in borderline resectable patients.
Yeah. So the final session actually is, dealt with HCC management, and which was kind of a wasteland of treatment options just a few years ago. It's now seen, I wouldn't say an explosion, but several treatment options come about. Second-line data after sorafenib with regorafenib, second-line data of nivolumab after sorafenib, then cabozantinib data being positive, lenvatinib data in first line being kind of on par with sorafenib data with better response rate and a longer progression-free survival. And the discussions we have, and I think this is an open question right now, how do you best sequence patients, how do you identify, how do you best sequence treatment options, how to identify patients for one treatment sequence versus the other. But I also believe, and this I think is important, we'll see more patients that should not be kind of taste to non-treatment option anymore. I see, HCC had been in the hands of interventional radiologists for a long time, and we all need to make a switch in moving patients to medical therapies a little bit earlier because we need them in good performance status because we're now sequencing patients through, let's say, 3 lines of therapy, including immunotherapy. It will be interesting to see how the first-line immunotherapy versus sorafenib data will apply eventually and to really establish a better treatment outcome for patients with HCC.
Yeah, I think regional therapies remain an important part of treatment, particularly for liver-confined disease. We probably do see improvements in progression-free survival and disease control. But now we have clear paradigms for treatment, which currently would be a tyrosine kinase inhibitor as initial treatment. Now we have a choice between a drug like sorafenib versus lenvatinib. Although there was no survival difference between those 2 studies, lenvatinib was non-inferior, but it did have a higher response rate and a different toxicity profile and potentially better progression-free survival. So we may have options now with first-line treatment. We await the results of the head-to-head comparison of an anti-PD-1 inhibitor versus sorafenib in first-line treatment. Second line, we now have an approved agent, 2 approved agents. Patients that progress on sorafenib, we now have the approval of regorafenib. Very interesting that regorafenib had a real measurable response rate in second line compared to very little or no responses to sorafenib first line. So standard second line treatment, regorafenib. Recent approval based on large phase 2 data sets for nivolumab after progression on sorafenib. That nivolumab is now available to patients as a second line salvage option. Clearly lines of treatment are developing and evolving, and we now also have a third option, second line, cabozantinib. This is a MET inhibitor that improved response, progression-free and overall survival compared to best supportive care in patients progressing on first-line sorafenib. So now we have options first line with different tyrosine kinase inhibitors, potentially the option of a PD-1 inhibitor if that shows to be better than sorafenib. Options for second-line treatment, including tyrosine kinase inhibitors, anti-PD-1 therapy, and now the MET inhibitor, cabozantinib. It is an exciting time where we've gone from having one approved drug to now having defined sequences of therapy, and we look forward to debating the issue of whether immunotherapy up front will be better or whether we'll stick with the paradigm of tyrosine kinase inhibitors.
And to wrap things up, I mean, if you want to see these discussions live, of course, there's a great opportunity next year. Come to New York. We'll have the great debates and updates in GI Oncology again here in New York. And David and I will host it, I hope. And so welcome to New York in 2019 for exciting debates and updates in GI malignancies.